Hello, everybody, and happy Thursday Night Live. Look who I have with us here today. Introducing Dr. Eyal Botzer. I said it my way again. I'm sorry. A pediatric dentist. I practice anymore. A pediatric dentist and tongue tie researcher. He graduated from the Hebrew University School of Dental Medicine in 1990 and completed a postgraduate program in pediatric dentistry in 1995. After serving as a research fellow at NYU, specializing in cleft, lip, and palate treatments, he has directed the Pediatric Dentistry Clinic at Tel Aviv Sourasky Medical Center since 1997, focusing on neonates with craniofacial anomalies. A founding member of the EATP and the IATP and a leader in tongue tie research since 2000, Dr. Botzer co-authored Ma Hakesher, performed thousands of procedures in newborns, co-founded BAM-Medical Ltd, developers of TongueGym, and established the Tel Aviv tongue tie and breastfeeding research in 2019. Tongue tie from birth to adulthood and the effect of oral dysfunction on our growth and development is our topic today. I am so honored to have you here on A-Ray Circle stage. And we were just mentioning before we came on live, you are in Tel Aviv, you're in Israel, one of the most beautiful and magical places I have ever visited in my whole life, and we're praying for you.
Thank you, and I hope it will be without interference, like heavenly interferences. And I will share my presentation, and I will go over how you presented me because it's part of my trail.
But yes, fix anything that I said wrong, please.
I said everything very good. Okay, so do you see my presentation?
I do, and I see our logo. Thank you. Looks beautiful.
Okay, so thank you, and really honored. I'm going to talk today about tongue tie from birth to adulthood and the effect on our growth and development. So let me just make this one a little bit. Yeah, and I have a bar right in the middle of my screen. So on the very first day of my dental and medical school, one of the forefathers of medicine in Israel, Moshe Rachmilevich, told us half of what you're going to teach you here is not true. The problem is we don't know which half is it. And today I'm going to talk about this half and a little bit more because it's things that we were not told, or some of it is not true, or we weren't even taught. So I wanted to talk about that. It's a very large topic, so please take a photocopy of this screen. There are so many resources over the net, and in order to get a little bit more of an understanding, go to those websites. Everything is out there, and there is a lot of information out there. There are books I have on the topic from 1995, 2010. Many books, I put just some of them. And I think the book Breathe by Jens Nestor has done a lot of changes in people's mind, in Israel anyway, because if you give it to a physician, he reads it out and maybe start thinking about things he wasn't taught. So I really recommend this book. There are many other ways to enlarge your knowledge. Among them are conferences, and I really recommend going to conferences. Here are some of the conferences that are in line, like in September in Argentina, in Europe, in Kazakhstan, I think it is in October. We have in Israel our third in a row meeting about which is called Face Forward. It will be in English. And we had two which were amazing. And the tongue time 2027 when we met in 2026, Renata, and it was really a very great meeting. So a disclosure, I'm a co-founder of BAM-Medical. We invented the LiPR device, which is now called the TongueGym. I'm no longer involved with the company, and it's a tool for tongue training. I treat...
Sorry. I have it here with me. I was just sharing about it. TongueGym now. Thank you for sharing. I love this thing.
So now I hope it will be back on the market because it was We had issues. And the company, we had a lot of issues with the new device, and I think it's a great tool, even though, like I said, I have no interest in it whatsoever now. And I treat patients with tongue ties in my private office. I'm getting paid for that. I'm salaried director of pediatric dentistry at the Tel Aviv Medical Center, and we've opened in 2019 the multidisciplinary clinic on tongue tie research and treatment of breastfeeding children. And as you said, in 2024, I co-edited the book Ma Hakesher, which means, what is the connection? How is it all connected? This is the book. It's in Hebrew. We should translate it. A lot of clinical photos. We'll do it one of these days. And this is our clinic and the research and treatment for nursing and ankyloglossia. We have several rooms for breastfeeding and an operatory room, a small one for the children. Please come and visit us. And this is one of the establishing team. We have a lot of lactation consultants, dentists, and body workers. So how did I get into this field? I graduated dental school in 1990 from Jerusalem, and then pediatric dentistry. I spent 1 year at the plastic surgery department of NYU. We performed something which is called NAM, nasoalveolar molding. This is how you take a child with a cleft lip and palate, and you correct him by soft tissue elongation and cartilage molding into a better case for surgery. It's a teamwork. I've been always working in a team, and this is great. So these kids got much better results in their surgery. Then I established the pediatric dentistry department at the Tel Aviv Medical Center, and I started research on tongue tie in the year 2000. It started because of a lactation consultant who told me, why don't you treat those tongue-tied babies? And I said, what is this nonsense? And then my daughter was born in 2002. She had severe breastfeeding issues. She's my third child. The older kids were breastfed beautifully, and this kid really killed my wife. But I did the frenotomy on her and things improved. So I really changed my attitude because I know how much we can help with that. So what did I think in the year 2000? I thought that tongue tie and breastfeeding is nonsense. Labial frenotomy is only for orthodontic reasons. Sleep disorder in children, it does not exist. Breathing, posture, ear infections, malposition of teeth, ADHD, bedwetting, all are predestinations or predetermined. If you have it, you have to deal with the consequences rather than prevention. And what do I know today? Well, everything is connected. Good oral function means correct tongue posture, nose breathing, breastfeeding, craniofacial development, wide airway, good sleep, good behavior, speech, balanced vagal tone, and much more. So it's a change in what I've learned, and I hope to transfer it to you. Before we start with things that we must have in our mind, and these are the form and function are so well connected. And let's talk about function and dysfunction. So, something is rushing here. I'm sorry. So what is proper function? When all systems function in harmony without compensations. And after all, we are built as a tensegrity model. Our body is, I'm sorry. Maybe one of my rehearsals, I saved the timing and it's not working, sorry. So tensegrity model, hold on, I'm sorry, just a second. Maybe I'll go out of it and try.
You're totally fine. Take your time.
Yeah. Let's try to do maybe. I hope it will not run. Okay, so no, it's rushing in. Just a second. You know what I'll do? I'll do rehearse timing again, and then we'll see what's going on. Hold on. And we'll rush into where we've been. You see it? Everything is. Do you see it all?
Yes, it's perfect.
Okay.
I can see everything.
So function, dysfunction. So good function, proper function is when all systems function in harmony and there are no compensations. After all, we are built as a tensegrity, meaning rigid elements and soft and tensile elements, which is mostly mediated by fascia and muscles. And when we press on one end here, there will be compensations or changes in other areas of the structure. And when we talk about dysfunction, it means when the function is impaired and there is some imbalance. And compensation will occur as if we have a pebble in our shoe and we'll start limping, and then it will affect our pelvis and our posture and so on. So it can provoke some kind of a vicious cascade of dysfunction on different systems. For example, if we don't breathe well, we'll have a stress response, will lead to a low vagal tone, meaning sympathetic system is much functioning harder than the parasympathetic system. So we'll have low vagal tone, it can develop anxiety and many more effects on our whole body and well-being. So fascia and vagal tone are kind of new buzzwords that, like I said, we were never taught about that. Now I want to show you breastfeeding. It's a video fluoroscopy by Adran from 1958, where you see a breastfeeding child using X-ray. You can see the breast and try to focus on the bolus of food that he's swallowing and the way his tongue is moving in a peristaltic-like movement, like a wave movement. And he did the same thing with a bottle. And again, food goes into the esophagus of the child, but the size of the bolus, the behavior of the tongue, the forces that are working here on the palate, maybe the tongue movement and muscles are working totally different than the breastfeeding child. So this child will live and it will be food will get into his stomach, but the effect on the muscles of the head, neck, palate are all so different. So our tongue is a vital organ in deglutition, mastication, and speech. It also exerts an influence on the dental occlusion, the craniofacial growth, and the facial form. It starts in the embryo, starts at the 4th to the 5th week of pregnancy from the bronchial arches. The tongue starts to separate from the floor of the mouth by a process of apoptosis, cell death by the 12th week of gestation. It starts from the tip of the tongue backwards, and incomplete separation leaves tissue that restricts the tongue mobility. It is called the frenum. It's a bridle, meaning by definition there is a restriction of the movement, and it's a normal anatomy. Sometimes it's more severe and sometimes it's less severe, but everyone has a frenum. Almost everyone has a frenum. One of our works demonstrates that. So the oral cavity contains several frena or frenulums. The lingual one, which we'll focus on today, the maxillary labial frenum, the mandibular frenum, which gains more attention these days. No research actually, but case reports, and the buccal frena. And I have some experience with that. This is a new kind of topic, but we will not discuss it in this lecture. A little bit of history. There is documentation of tongue release frenotomy since 10,000 year BC. In the Middle Ages, it was done in France, a frenotomy with the midwife's fingernail. Until the mid-50s, it was part of the routine assessment and treatment for tongue tie. And routine frenotomy was stopped due to technical complications and alternatives. So people didn't recommend breastfeeding. I think in the 70s, only 24% of the mothers tried to breastfeed. This is an old group director from our neonatal unit, an old neonatal unit that moved to our new hospital. So this is from the 50s, the same tool that is used today. And then we had the formula age. Why should you breastfeed? Give him something we prepared especially for this child. And there was no scientific data to support that tongue tie and breastfeeding and feeding difficulties really exist. And then the pendulum shifted and breastfeeding awareness made a comeback and started new research on tongue tie. And as of recently, we have almost 1,000 articles on the topic. So there's quite a large body of research on that. One of the peaks of the world of tongue tie is from 2015 in Brazil, the frenulum inspection law. Unfortunately, it didn't progress to other countries where every child was supposed to be checked for his tongue once they were born at the hospital. So I know it made some issues with the pediatricians in Brazil, but to me, this is how life should be in the modern world. Now, Charles Horton wrote something like that. Perhaps not many subjects in medicine and dentistry have aroused so much controversy, have been surrounded by so much superstition, or have created as much concern among the lay public as tongue tie. He says, even today, the controversy has not subsided, and although the subject is approached much more rationally than previously, one still finds physicians and dentists who clip every prominent lingual frenum, while many of their colleagues strongly advocate no surgery at all, even in the more severe cases of tongue tie. And guess what? It was written not long ago in 1969. So not much change, I think. Maybe we have a much bigger body of evidence, but we can still find many pediatricians, ENTs that says, hey, you don't need to do anything. I've never seen a tongue tie. I heard that from very distinguished pediatricians. So the controversy was shown by the article of Messner and Lalkia in the year 2000. 90% of pediatricians said tongue tie does not cause any feeding issues. 70% of the ENTs said it does not cause any feeding issues. But 99% of the lactation consultants says tongue tie does cause feeding difficulties. So we have two populations of professionals that should work together, but rather they are, every group says, hey, they are crazy. What do they talk about? Or, hey, they can't see it's part of the problem. Today, I think the 90% of pediatricians is not true. I think it's about 50% of what I see, because they are not taught that tongue tie has any issues, anything about tongue tie. And while the pediatrician is the person to say whether breastfeeding is correct or not, and this is something that should be up to a good lactation consultant. So in the year 2010, you can see something's changed. There is a rise in the awareness of tongue tie. This is Google Trends. I looked for ankyloglossia versus tongue tie, and you see in the year 2010, there is some kind of rise to it. I also added the PubMed research articles on the topics. One is ankyloglossia and the other one is tongue tie. And you see there is a rise, pretty impressive. So in those 16 years, we have almost 800 new articles on the topic. So there's a bigger group, body of evidence now out there. And I'm not going to go into it. Everyone who wants to get deep into the subject, please read. There is so much research out there. But still, it's a young field. It's an emerging field. I would say it started in 1990, the first articles, and now we are talking, and big change started in 2010. And why did it start? I kind of take responsibility for that. In the year 2009, we had a tongue tie summit. Alison Hazelbaker, grouped in one room in Florida at the big lactation consulting meeting. She said, anyone who wrote any article on the topic, please come. You're invited to this meeting. We sat in one room, people from all over the world, from Canada, US, Australia, England, Israel. Myself is here, and Ray Fuhrer here, Larry Kotlow. This is Kathy Jenna, and Betty Korillos, who is a surgeon. She, I think, was the mother of all this group. She taught everyone so happily. And we had a video conferencing, not a Zoom, a video conferencing with some other professionals around the world, like Brian Palmer and others. And each and every one of us kind of discovered that we didn't invent the wheel. Everybody else in the room have the same understanding of function. And we were just at the beginning, 2009. And we decided to establish this organization, which is called IATP, International Affiliation of Tongue-Tied Professionals. And the T stood then for tethered oral tissues. Instead of just tongue tie into tethered oral tissues, as I said, we see other tethered oral tissues in the mouth, the other frenums. And today we could call it also the fascia, which is, and the function. So it's not only tongue tie. Tongue tie is kind of a misnomer. And like in every successful organization, they started to quarrel, and a new organization came up, which is called ICAP, International Consortium of Ankylofrenula Professionals, meaning professionals from different people from different professionals, not only doctors, not only lactation consultants, not only speech pathologists. And this group is kind of functioning still. They have a meeting now in April in Portland, and there will be very nice presentations there. Sorry, I will miss it. And one thing IATP did is we tried to get a definition, because the definition is still a problem. And the best group of professionals then said persistent lingual frenulum, meaning an embryologic remnant of tissue in the midline between the undersurface of the tongue and the floor of the mouth. And we call it a tongue tie when there is a restriction of normal tongue movement in the presence of persistent lingual frenum tissue. So this was the best definition we tried to develop, but it's a very bad definition, because persistent lingual frenum, everyone has one. And normal tongue movements, what is normal at the age of, in the womb, or what is normal when you are born and you need to breastfeed? What is normal when you transfer to solids? What is normal when you are 50? So the best definition was a very bad one. So we tried to change it a little bit, like tongue tie is a restricted function because of the persistent lingual frenum. And today's definition of dysfunction is oral dysfunction, that the impaired function can be caused by other factors, not only the lingual frenum. It could be caused by high palate, by neurological issues, by muscular issues. A lot of issues can cause dysfunction. And function with oral dysfunction is like walking on a tightrope. You have a lot of compensations in order to perform a function. Unlike if you don't have an oral dysfunction, everything works good, you can do it without exerting so much energy on a simple function and without. So these are all cases of tongue tie. It's a neonatal condition that interferes with proper function of the tongue because of the lingual frenum. And as I said, it's only part of the picture. Now, let's see how the palate develops. In utero, what shapes the palate are the forces that are working on the soft bones. And the tongue is what shapes the palate. When we swallow and when the swallow is correct, the tongue presses against the hard palate and then the soft palate, and the bone is molded to the correct position. It's a wide shape that follows the tongue when the tongue functions well. And the tongue should be sitting up on the palate. And then we have a wide palate. We have a good occlusion on both sides. And breathing is through the nose. And when the tongue is down, then the palate is narrow. You can see the crossbite on both sides here. And this is most likely an oral breathing. So this kid that is breathing through his mouth will have a narrow palate. And this is something from Brian Palmer's website. When we have a good support of the palate, the floor of the mouth is wide, and we have the blue thing is the airway, and we have a wide nasal airway where we should breathe through the nose. When the tongue is not supporting, then the pressure from the sides, from the cheeks, diminishes the size of the palate. We have a high palate, and we lose a lot of airway size, nasal airway, because the palate is narrow. Now, what happens to the nasal septum? So if we have a wide, the septum can be straight, but when the distance is diminished, we may have a deviated nasal septum. And Roy Fuhrer from Israel, which I mention him a lot, He said, when you see this rigid palate, the ridge on the palate, you can suspect that the palate shape looks like that. You see those cavities on both sides of the ridge, and this ridge is the septum. I don't know how deviated it is, but there is definitely, and it's definitely by definition, I mean, a narrower palate with less nasal space, nasal airway space. And we try to research that. We can scan the 3D baby with a palate, and now we need to find a way to examine their septum and see whether those with a narrow palate and the ridge in the middle of the palate have a straighter nasal septum. And in contrary to the other baby that you saw before, there are babies that are born with a very big distance between the tongue and the palate, like a bubble palate. And we can compare it here. This one, the palate follows the shape of the tongue, and here the shape of the palate is totally different. And try to imagine this baby on the right trying to breastfeed. Where will the mother nipple be? And how much air will he swallow? And how many compensation will he have to do in order to maintain the nipple on the palate and extract the milk correctly? Will he exert forces with his gum pads on the nipple and bruise the mother? He will swallow a lot of air. He will not be efficient. We'll see so many misfunctions, and following that, a lot of compensations. So from day one, there is a child that is on the right track for better function, and the other one will struggle with function. And tongue tie is a cause, many times it's a cause for this kind of anatomy. And there is research to show that. The group from Stanford by Audrey Yun, Sourasky, Guilleminault, Stanley Yu, showing that narrowing of the maxillary arch and elongation of the soft palate this is what they studied. And the findings suggest that variation in tongue mobility, meaning when the tongue has not the full mobility, may affect maxillofacial development. And there is another article by Guilleminault who showed that short lingual frenum is connected to obstructive sleep apnea in children. And I do not agree with their conclusion, which means short lingual frenum may lead to abnormal orofacial growth early in life. We understand that. And it's a risk factor for development of sleep disordered breathing. And they recommend that careful surveillance for abnormal breathing during sleep should occur in the presence of a short lingual frenum. Well, I say, hey, you see there is a problem, the palate is narrow, there is a tongue tie, go ahead and fix it and put the child on the right track as soon as possible. And today we try to find ways to expand the palates of the newborns which have with tongue tie or without tongue tie, with oral dysfunction and a high narrow palate. Another thing that is affected is the ears. When we have a high palate like that, the Eustachian tube is very flattened and the drainage is poor. And they found, this is in Pediatric Dentistry for 2008, that they found a significant correlation between the presence of a high palate and the earlier occurrence of acute otitis media in young children. And their conclusion, which is also, I do not agree with that, they said that the shape of the palate in the neonate could be used to alert the pediatrician that this child is in predisposition to acute otitis media. Hey, you see a high narrow palate, look for the reason and treat it and try to expand and get the function better. And again, tongue tie means a high palate. High narrow palate, it's very difficult to function in breastfeeding with that. Also, we'll have complaints that the child doesn't like to have any bottles or is not efficient on them. It doesn't want a pacifier because there's not much fun when the palate is so high and you can't get the feedback from the palate and the tongue is not pressing it against it. So this is a functioning issue. And just to show you again how foreign function are connected, this child was born without a tongue, and look at the shape of her lower palate. Hold on a second. I have a cat issue here. Just a second.
There's no such thing as a cat issue.
She's,
They
she's
can
out.
come hang out. We love kitties.
Okay. Okay, so now I want to show you one photo that it doesn't prove anything, but it explains. When you see a child, someone with an anatomy like that, you see the form, this form cannot function well. This kid will never walk properly unless he has surgery to correct it. And exactly the same thing is this tongue tie. He will not function well with this tongue tie. He will compensate. He will live. He will function, but he will not function optimally. And now I want to go through a kind of a vicious cascade of malfunction. So we have this malfunction, maybe tongue tie or oral dysfunction. So we started in the womb when the baby does not swallow the amniotic fluid correctly and will have a high palate. And the high palate may lead us to impaired breastfeeding and to bottle feeding. As you saw, it's not the same good function when you breastfeed versus bottle feeding. And look for the compensations that they show. Sloppy feeders, nursing callus. Look at the effort and how much compensation this child is doing in order to suck on something. They swallow a lot of air. There are several articles that show that reflux signs are contributed to tongue tie and are being cured following the release. Poor weight gain, high tone. This child didn't need a tongue release, but he did need some kind of a body work to release his very high tone, and then he could start breastfeeding better. So we have a high narrow palate, and it doesn't go away if you don't treat it. It stays, and the dysfunction stays. And we have mouth breathers, and they sit with their mouth open, the tongue is down when they are when they are getting older. And this mouth breathing affects the high narrow palate, and the high narrow palate, it's a vicious vicious cycle that one increases the other. And remember, we talked about the ear infections with this article from 2008. And so the child goes to sleep, he has an ear infection, he's suffering from the pain, he doesn't hear well because he has fluid in his ears. They don't sleep well, they have sleep disorders, they are snoring, they have sleep apnea. And when the child goes to school after a sleepless night and they didn't get good sleep, they will show signs of ADHD-like symptoms. An adult will go and fall asleep while driving, and a child will be showing signs of ADHD. Other issues that may happen following the mouth breathing, we must change our posture in order to open the airway. He needs to open his airway to get air, but this may be also tone, like vagal tone or muscle tone. But we see a lot of children and adults following the release of the tongue, how their posture is improving. Posture is improving because their airway does need to be through the mouth. And when you need to breathe through your mouth, usually there is forward head posture, and then the amount of strain on the back, on the upper, on the neck, and on the lower back is being increased. And there are all kinds of formulas to calculate how much the strain on your back is increased by every inch of your forward head posture. And all these affect our vagal tone, as I said. Now, as a dentist, and this is what we learned from this whole vicious cascade, we learned that when you are mouth breathing, you may have violent oral flora and more cavities and more gum disease. So I had to learn the rest by myself. Now I want to pay tribute to Roy Fur, a good friend of mine. We went to school together. He was 2 years ahead of me. He passed away 6 years ago, and his vision was so different. He looked at things and really opened the eyes of many people, including myself. And Roy had a huge flow chart. It's in Hebrew, and I asked an AI engine to translate it to me and translated part of it to see how one things lead to another. So lower teeth shifting, and he says there is speech impediments and stuttering, maybe, but learning difficulties, chewing issues, and then we'll have hormonal distractions, this dysfunction, and ear infections, and tongue mobility. And the tongue is not on the palate, so we'll have a high narrow palate and posterior crossbite and so on. So everything is connected to everything else. And whenever an article is discovered, we see that one of those understandings of his are being lit with, yes, there is a research to show it. We're talking about the gut and posture and everything. And today we are talking about oral dysfunction. And if you know the AMOT, they have this poster of oral myofunctional disorders. And it includes mouth breathing, poor mouth posture, anterior tongue thrust, bilateral tongue thrust, tongue tie, lip tie, atypical swallow, habits, chewing disorders, facial mass dysfunction, hypotonic masseters, speech misarticulation, tonsils, increased tonsil adenoids, TMD, sleep disorders, bruxing, clenching. We can go on. Low tongue posture, snoring, malocclusion, cavities, and gum disease, we said. Dentists know that. Changes in saliva, restriction like maxilla, which is backwards, and also high palate. Tongue scalloping, which is a sign for poor tongue posture. Allergic shiners, we'll see that in a minute. Eustachian tooth dysfunction, aesthetic changes, macroglossia, abnormal breathing, tinnitus, infant feeding problems, forward head posture. I don't agree with everything, but one thing leads to another, and there are so many things in the pool of dysfunction, and we must always not overlook them. And for another example is myofunctional therapy and Parkinson's disease. There's a guy, his name is Antonio Farente in Italy, and he sees a connection between Parkinson's disease. First, even the seeds of Parkinson's disease are sowed in early life, and because of tongue is not stimulating the incisive papilla. So what he says is that the role of lingual stimulation, he needs proper tongue posture on the spot, on the incisive papilla, where the nasopalatine nerve is emerging, and this way you trigger the trigeminal nerve, which goes up to the brain, and you get better stimulation of the brainstem. He says that dysphagia, when you correct the muscles with myofunctional therapy and you get good lingual palate contact, you reduce the risk of aspiration in those Parkinson's disease patients. And they can swallow and they have less drooling. And speech impediments, when you have stronger muscles following the myofunctional therapy, you get better clarity in speech. And he talks about the neuroreflexes, like chronic lack of trigeminal stimulation due to the low tongue posture may exacerbate the extrapyramidal system dysfunction and the movement. And myofunctional therapy serves as a non-invasive tool to modulate neurovegetative balance and systemic muscle tone. And the clinical goal of myofunctional therapy in Parkinson's disease is integrating the myofunctional therapy in protocols along the pharmacological treatment to get better quality of life. So this is just one way of seeing how it affects, poor oral function affects our health. And this is one of his works where he says, effect of myofunctional therapy on the therapeutic treatment of Parkinson's disease. Now, high narrow palate and adults. This adult, he managed to grow in his 40s, and he's a well-functioning person, but he suffers from asthma, rhinitis, allergy, so many symptoms, and poor hair life quality. So this guy managed to live, and like I said, you won't see, he will not complain about it because he doesn't know, but he could have much better life. Now, correcting it at this age is much harder than preventing it. And I put on the first slide there about the eye spy, how the eyes can show us about the poor function of the mouth when we see the scleral show here and the shiners. These are all connected. I really recommend you to read that. And posture, I told you the Italians are well in this field of posturology. And this is a work from 2012 by Giovanni Olivi, who showed how the posture of this person improved 4 months following the frenotomy because he could breathe easier. And this article by Sourasky, who shows how frenotomy with the myofunctional therapy gets a better function of mouth breathing, muscle tension, snoring, clenching. Today has another version of with much better results of is in 2025 research that they did. This one is from 2018, I think. So when we go to treat tongue tie or oral dysfunction, we have a teamwork. And when a newborn, it's a lactation consultant who is the team leader. We should have a pediatrician on board, but depending who is the pediatrician, I hope someone that can understand the function. And we need the physiotherapist, the body worker, and the surgeon is way in the back. Sometimes we also need a SLP for severe feeding issues. On toddlers and adults, the team is different and the problems are different. In toddlers, it's feeding and breathing issues and malocclusion, and then we have the speech pathologies. And we should have the ENT, orthodontist, pediatric dentist on board, the body worker, and the surgeon is also part of the team. And with adult and adolescents, it's breathing issues, sleep issues, malocclusion, and posture. And again, the team has doctors, body workers, and surgeon. So let's go about the tongue tie. Now we are into the tongue tie. My 45 minutes are over, so let me know if you want me to stop. We are.
How much longer do you have? Because you can either keep going or you can come back.
3 minutes.
Oh, no, please keep going. You're fine.
I think. So we have, as I said, tongue tie, the definition is problematic. The prevalence is unknown. You can see in the literature starting from 0.02% to 12 or 21% in Brazil from 2016. There is a work from 2040 in 1948 in Japan. They said 59.2%. And this is where they first also talked about the labial frenum, how it improved, breastfeeding improved following a release of the labial frenum. This work from 2018 from Brazil showed about 34% of tongue tie or lingual frenum alterations. And this work from Spain, 2020, they showed 46.3% of lingual dysfunction, and they said only 70% were symptomatic. So they would say about 32%. And I think it's about 30% of the population that has some kind of a newborn have some kind of a lingual issues. Then it may continue further. Sorry. How do we classify the tongue tie? We have several classifications, the anatomical like Kotlo, Corylus, and Batat, all kinds of the classifications that are based on the anatomy. Some of them are based on the functional, like the Ellison-Hazelbaker ATLFF or the TRMR. And there are classifications that combine the anatomy and the function, like the Martinelli and the TRQ by Richard Baxter. So we combine function, anatomy, and the overall clinical effect of it. And then the recommendations are whether to do any treatment or not. And when we decide to do any treatment, so it starts with consulting, whether it's a lactation consultant and SLP or a myofunctional therapist, and then a body worker. We continue with tongue training and neuroeducation. The myofunctional therapist, the sleep and language pathologist, They can use all kinds of tools like the TongueGym, Froggy Mouth, MyoSpot, MyoMunchie, MyoTape, so many other tools to assist with for the treatment to educate the brain and train the tongue and the mouth. And you see, there are so many tools that can be assisted, and it's up to the myofunctional therapist to teach the patient. And then, if things fail or they need an assistant, then we go to the surgical correction. We can have frenotomy, where you just do an incision of the with any kind of tool. You can have scissors, scalpel, electrocautery, lasers, depending what kind of lasers. Frenotomy and then frenectomy, which is a real excision. It's surgery with sutures. It has good results for certain indications, and sometimes it's an overkill. And frenuloplasty, which is rather a rare procedure, only under general or complete cooperation of the patient. So our take-home message: tongue tie is a common condition. Functional impact should be evaluated as soon as possible. Effects are not limited to the oral cavity. It can affect feeding, growth, breathing, sleep, airway size, behavior, neurological development, and function. Sorry for the spelling here. And early intervention may prevent compensatory adaptations. And it's a multidisciplinary team approach, which is essential. And thank you very much. And that's it.
Yay, thank you very much. And I'm so glad that you're able to do it without any sirens or having to run into the bunker.
Yes, I'm even more happy than you.
Oh my gosh.
Not much fun.
Insane, insane. I may ask you a few questions that you already shared.
Yeah.
It's just so we can share it on social media.
Yeah.
What first drew you to tongue tie research after your work on cleft lip and palate at NYU?
Okay, so as I said, I came to Tel Aviv and I met one of the most amazing all generation of lactation consultants. His name is Esther Grunis, and she said, let's try and make a cleft baby breastfeed, which is a nice challenge. And we tried, we used all kinds of special plates that, by the way, I think we're going to move them back into therapy because I have a lot of experience with cleft. We didn't succeed with that, but hopefully we'll have a better tongue function thanks to those plates. And then she said, okay, we failed getting a cleft palate to breastfeed. What about tongue tie? Why don't you release the tongue tie? And then I said, what nonsense are you talking about? We started research in 2000 following this article by Lalkia and Metzner. And that's it. When my daughter was born, wow. So it's an amazing change.
How was it releasing your own child?
And
Was it
remember,
different?
I started doing the releases in the year 2000. I did several hundreds by then. So I was experienced. And the thing was against my wife's will.
That was the
She
worst
said,
part.
what are you doing? What are you doing? And I took it and I did it with scissors at home on our bed with some magnification. And it's a very simple procedure. Listen, if a midwife can do it with her fingernails,
Right?
yes. So I could do it. And it was an immediate improvement, like we see today.
Incredible.
Very sensitive.
How does untreated tongue tie in neonates impact breastfeeding success based on your thousands of procedures?
Say it again, please. How
does untreated tongue tie in
Yes.
babies in the NICU impact breastfeeding success when they're out of the
Okay. So today,
little tiny ones?
I see those kids at our hospital. We see the babies that are hospitalized for the first 3 days of life. They are all screened by lactation consultants.
Wow.
Those that are in the NICU, they have other issues, but the mothers are pumping. So because it's very important for a preemie to get breast milk.
Yes.
So
And after they leave the NICU.
yeah. Yeah, and after they leave the NICU, usually they go home. They don't, and so we don't see those in the NICU. We see
Okay.
the healthy babies that are not breastfed well, and those from the NICU, they would come to us after a week or 2 weeks or 3 weeks once they were released by their lactation consultant in the outside in the community. And when you have a tongue tie, it doesn't necessarily mean that you have breastfeeding issues. It's a diet,
Mm,
and it's a first child, it's a third child, it's a fifth child. There
yeah.
are so many variants to this thing, but the good lactation consultants see that. In my opinion, if we see a tongue tie, meaning a frenum type 1 or 2 by Corylus, it
Mm-hmm.
means that the, the tongue is tied. It will not function well. So I'm definitely for releasing it, even if they are, let's say they are not breastfed. Every bottle will, they will succeed to feed with a bottle. And the mothers don't not
Mm-hmm.
always breastfeed. So if you see a potential functional issues, then I would do it.
Do you see a lot of pushback from healthcare professionals in Israel?
Meaning that they don't support it.
Mm-hmm.
It's changed a lot in the last 25 years that I'm in it. They respect me. Some of them don't agree with me. They say, okay, I know you, I respect you, but I don't agree with you. Like the head of
Mm-hmm.
my pediatric hospital that we are staying in. But he respects that. And sometimes he refers to it. It's kind of a joke. And as long as they get the feedback from the crowd, and I think the research will do it. So it's all up to the research. Unfortunately, I don't do enough research, but there is also the ENTs are, I think, in my hospital are the worst, but we managed to get.
There's usually in different parts of the world, it's one profession versus the other.
Yes, yes, yes.
Mm-hmm. I think in the United States, I mean, it depends. Pediatricians are really tough to talk to. Some
Because they
ENTs
know everything.
I've had some local ENTs that uh, I've had my patients sent over to them for tonsils
Yeah.
and adenoids, and they said they didn't have a tongue tie, it was all a fad. But
What I say to
I
them.
want to send the patient back for them to see the difference. Like children that were barely speaking now, you know.
When I see when I lecture to the ENTs, I tell them every one of your patients is a functional failure. If them need to get to you and have surgery, it means that they are functioning. This is a functional failure. Always look under the
Wow.
tongue and do the right evaluation. Their evaluation is if
Yeah,
they can stick their tongue out of the lips. This is a stupid
that's
evaluation, but
right.
we need to educate.
Yes, 100%. That's why we're here. Invite your colleagues to watch this. Send the link for
Yes,
every
yes.
circle. Every Thursday, we have this for free. Anybody can join. Um, Looking ahead, how might early tongue tie intervention change our understanding of lifelong growth and development?
So it comes in stages because when I got into it, all I thought was, okay, tongue tie, I will risk it, breastfeeding will be okay. Nobody talked about breathing, nobody talked about sleep, nobody talked about other ways of feeding, nobody looked at their palatal width or so we learned that ourselves, and by going to those meetings and meeting the crazy people that are saying, "Hey, the tongue tie is related to breathing." I said, "What is this person talking to me about?" So we have to keep an open mind, and we need this research that follows longitudinally after the patients. Let's say how many
Mhm.
kids that had breastfeeding issue had a tongue release and breastfed well, and comparing them when they are 3 or 4, how many ear infections did they have? We can do that. How many times? So these are this is kind of research that should be done, or
Mhm.
longitudinal research to show. And the problem will always be the control groups. But when you have a mass group of patients, then you may have good data.
Wow, that is incredible. Thank you, thank you, thank you. I know I met you at tongue time. I cannot wait to go back to the next one. St. Gallen was amazing. Now in the summer in 2027. Do you
Well, I
have
do hope November in Israel, once we have peace around in this region,
That's true.
Yeah, we have
That's
something
true.
to strive for, a meeting in Israel when everything relaxes.
Oh, I really want to go back.
A
It's,
peace
and I didn't
meeting.
go to Tel Aviv.
Yes.
Where's the meeting going to be at?
It's going to be near Tel Aviv, yes.
Okay, awesome. Yes, I'd love to come. Thank you everybody for listening. I do have one small announcement to make. For those people who live in countries that cannot afford the Airway Circle membership, we have created an Airway Circle podcast membership. So you get the audio for these talks instead of the visuals, and it's only $99 a year, but extremely affordable for everybody. So share this with your friends and colleagues in places where it's a little bit more difficult to be able to get the webinar portions. Last words, how can people find you? Do you want to talk a little bit about November?
So November is going to be our third meeting. We started with Barry Raphael. If you know, Barry
Yes.
Raphael is an orthodontist, which starts airway orthodontics. I met him many years ago, and he is the person that put the blocks in correctly in my mind about airway and breathing. And he came to Israel 2 years ago during the first war we had, and we had a called out meeting at our hospital. And then last year we had one with Samantha and Kathy Jenna and other amazing lecturers in Jerusalem, which was another amazing also sold out. And my dream is to have an international meeting. It will be in English, though, that's for sure. And once we see how the situation, I have so many people that said, if everything is okay, we are coming.
Yes.
So
I
November
mean,
5th
when
and
I
6th.
went,
Mark down your calendar.
yes, I'm definitely gonna write down my calendar. We'll share on Airway Circle. So last summer, I did a 10-day retreat. I think I mentioned it. I was in Egypt first, and then we were supposed to go from Egypt to Israel to go to Jerusalem, and everything was closed because there was a war. And we waited. We ended up going to Jordan for a day, and then Israel opened up. We were the first tourists to walk into Israel. So it was empty. All of the tourist places, there was nobody. It was just us. So it was very incredible that they were able to close these places for us for like 2 hours instead of you walking through for 5 minutes. So it was really cool. So it's gonna be safe.
It's the Holy Land, it's
100%. It needs to be protected. Thank you, thank you, thank you. We appreciate you. I'll keep praying for you guys. Hopefully this is gonna be over soon. And
yes.
we in this side of the world have no idea what it is to hear missiles and to have to go hide and to hear sirens in the middle of the night. I have a few friends in Israel, so we're going to be praying for you guys. Thank you so much, and we'll see you soon.
Bye
All right,
bye.
thank you. Bye bye.